a sixth of a mile away from here in another committee meeting. So we're going to have to move right along in this regard. So we do have a sign-up sheet. Delegate Freitas here. Good morning, sir. I draw the committee's attention to House Bill 533.
Thank you, Mr. Chairman, members of the committee. Everyone here is here to support this bill. So I have a amendment nomination to substitute, Mr. Chairman.
See if we get to the members before we adopt that as the vehicle before us. Without objection and by general consensus, it'll be adopted. So, House Bill 533 as substituted is before us. Delegate Freitas, tell us why your bill and what it does, sir.
Sure, thank you, Mr. Chairman. So essentially what this originally did, this was a far broader scope, and it had actually taken out certain medical boards and departments with respect to reviewing qualifications of veterans when they went before the Board of Occupational Licensing. Obviously, that was probably a little bit too broad. We already have some good systems working. Delegate Stolly has worked with boards of medicine to ensure that we can get medics and doctors from the military into the private sector. So what this bill essentially does at this point with the substitute is it just says the department shall take steps to promote awareness among veterans of the acceptance by regulatory boards within the Department of Professional and Occupational Regulations, health professionals, etc. What we're trying to do is take all the good work that we've done right now and making it easier for veterans to transition from the military into the private sector and make sure that they actually know this information and it's made available to them. We had I remember when I was out processing out of the military, it's come a long way. They make us a lot more aware of what options are available to us once we're transitioning to the private sector, but I just want to make sure that we're doing everything that we can to ensure that our veterans that are transitioning are aware of all the different benefits and steps that we take within the Commonwealth of Virginia to make sure that they can easily transition.
All right, members have any questions of the patron? Is there anyone in the audience to speak in favor of House Bill 533? Is anyone here to speak in opposition? Members have any questions?
Second.
Probably moved and seconded that House Bill 533 as substituted be reported. Members would vote on their electronic board. And that measure advances on a 7-0. I gotta vote on the other one. That measure advances on a 7-0 vote.
Thank you, Mr.
Sheldon,
Chairman.
you do not need to be at full committee. If it goes south, I'll prevent it from going even further south without letting you know.
Thank you, Mr. Chairman.
Yes,
You
sir.
did it,
Delegate
guys.
Ingram.
Good job.
Thank you, sir.
Good morning, sir. Draw the committee's
Mr.
attention.
Chairman.
Draw the committee's attention to House Bill 1524, 1524.
And let me tell you what, I was just talking to Mr. Johnson here for a minute. What we're trying to do is, I've talked to a group of doctors in Hopewell, and my daughter is a nurse practitioner with the firm. They have two big, huge storage bins that they're keeping records from 50 and 60 years ago. This practice has been in business now for years. The way the law is, they have to keep these records, and they're still keeping them. And some of these people, my daughter told me about one that they started seeing her when she was 18. They have records back from 50 years ago. This patient now is older, but they still have to keep these records. Well, with the patient's permission, it's with the Hospital Association, but Mr. Chairman, my original bill, it said that the Board of Medicine shall amend regulations governing the retention of patient records by health practitioners to require healthcare providers to maintain patient records for a minimum of 10 years from the date the record was created for an adult patient until the patient reaches the age of 18 or becomes emancipated, with a minimum time for record retention to 10 years from the date the record for the records of a minor patient. Mr. Chairman, ladies in the House, right now substitute does not do a thing. That's the problem. So I guess I need some more time to try to work this thing out. I don't know how to solve it, but if there is a problem, I don't understand why the hospitals have an objection to it.
All right, Delegate Ingram. Members have a question of the patron?
Like, we don't want to lose the substitute. I can tell you, the substitute does nothing. Give the patient permission,
All right, sir.
50 years old.
All right, hang with me just 1 second. Scott.
Yes, sir. Mr. Chairman, Scott Johnson, General Counsel for the Medical Society of Virginia. I talked to Delegate Ingram's physician practice. The current law today says that anybody licensed by the Board of Medicine has got to keep records on an adult 6 years after the last encounter. So the problem he described about treating a patient for 55 years, he's exactly right. So I had reached out to the Board of Medicine and the Department of Health Professions to see what can we do on this with these adult patients. The concern is if you put something in the law like the introduced bill has and just says you destroy them after 10 years, you may have a patient that's got some cancer diagnosis or important tests. Those records get destroyed, it's going to be a concern. Secondly, a Board of Medicine complaint could be filed against one of those physicians, and if the records have been destroyed, they're not going to be able to prove they kept them consistent with the regs. So what had been recommended to us in the substitute was to give the physician the option to either keep them for 6 years from the last time you saw the patient, or if the doctor wanted to, obtain consent from the patient to either say to the patient, here's your paper records, you want to take them, and they're yours, or if you don't want to take them, you throw them away. Now, why do we do consent? If we don't have something to document that that patient agreed to it, and a med mal case comes up, as Delegate Campbell will know, we're going to see a jury instruction called spoliation of evidence, meaning that the defending doctor is going to have a bad jury instruction because he or she destroyed the medical records after 10 years. If you've got patient consent, you won't have that problem, and that's why we took that approach. Be glad to answer any questions.
All right, sir. Delegate Hodges.
Thank you, Mr. Chairman. What are the current CMS requirements? Because typically they'll differ than the state, and that's the bulk of your patients.
Right. The reason we've got 6 years in our regulations is CMS can come back and audit you 6 years from the date of your service that you were provided. And so, some people keep them longer than 6 years, but that's why our regulations, and we wrote those probably 5 years ago, if I had to guess, make it longer. Yes, sir.
All right, members have a question? Yes, sir. Delegate
I
Ingram.
would like to ask a question. I talked to my daughter last night, and she talked to the doctors and said, what if they could just make it 20 years? In other words, they need to get rid of these things, and under the present law, they cannot get rid of them at all. And let me see what we can work out. You're going to have another meeting.
So, Delegate Ingram, we will not, but as you know, Chairman Orrock has been incredibly gracious to put all these issues together on the fly pretty quickly. We'll have a full Health Welfare and Institutions meeting next week, probably next Tuesday. Well, we'll have, yes, this morning, but next Tuesday. If you want
Mr. Chairman.
to carry it over until then, sir?
Yes,
All right.
let me see if we can work something out. All they want, and let me see what I can do with the doctors and see what we can do, and maybe we can get a compromise, okay?
All right, for the audience, is there anyone here that came to speak to 1524, given what you've heard? Is anyone that feels compelled to come up and share the wisdom? All right, and Chairman Orrock, I think you've been privy to these conversations as well. Chair needs a motion to carry over 1520. What do you want to buy for the day? Well, it's buy for the day. It's good. All right, how about a motion, my apologies, to take this buy for the day and give the delegate a tax? All right, it's been probably moved and seconded that House Bill 1524 go by for the day. All in favor, say aye. Aye. All opposed? All right, the measure passes to take by for the day. All right, next, Delegate Herring, I see you here. Delegate, please attention to 1054.
Thank you, Mr. Chair, members of the committee. I do have 2 line amendments.
Council.
Thank you. 2 line amendments, both on page 1. First line amendment will be on line 37. Strike comma as defined by the Department of Health. Second line amendment, line 38, after prevention, strike comma to a person 18 years of age or older for the purpose of treating a diagnosed or suspected case of chlamydia or gonorrhea, comma.
So for the members, lines 38 to 40 then would read, in cases in which the practitioner is an employee of the Department of Health and is providing expedited partner therapy and consistent with the recommendations of the Center for Disease Control and Prevention, the examination required by clause 3 shall not be required.
But actually, we will need to take on line 37 that after the Department of Health.
The
Take
word.
the and
The word
out there.
and,
So
okay.
it'll read, in cases in which the practitioner is an employee of the Department of Health and is providing expedited partner therapy consistent with the recommendations of the CDC.
Right. Members understand the amendments? Right. Without objection by general consensus, it will be amended as such. So House Bill 1054 is properly before us. Dr. Herring, please tell us why your bill and what this does. I remember we had some conversations probably back in 2011 or 2012 or so to this. So, but I assume you've got some new data since.
Well, yes, I do. The issue of people being infected has increased with chlamydia and gonorrhea. CDC still has a recommendation for expedited therapy. Just for background for you all, 41 states have implemented this practice. Again, just for background, for those who don't know, expedited partner therapy is a clinical practice of treating sex partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions or medications to the patient without the health care provider first providing an examination. Except for syphilis, partner management through the current patient referral process is not making a difference with STDs in Virginia. This bill will allow physicians to prescribe limited doses of medication without seeing the other patient to prevent the spread of the disease. Also, you will note in the bill, if you turn to the last page, what this will do is also provide a study, or basically a report, directing the Commissioner of Health to convene a work group so that we can basically evaluate the practice of expedited therapy and make recommendations. And also, this bill does have a sunset of 2020.
All right, members have a question for the patron? One in the audience to speak in favor of House Bill 1054. Yes, ma'am. Come on forward.
Dr. Lori Furlano from the Virginia Department of Health, Office of Epidemiology. VDH supports the bill and the administration supports this bill.
All right, thank you very much. All right, yes, ma'am.
Good morning, Mr. Chairman, member of the subcommittee. Good morning. Nicole Pugar on behalf of the American Congress of Obstetricians and Gynecologists, Virginia section. As it's been stated, data shows that gonorrhea and chlamydia are the top two reported infectious diseases in Virginia. The highest rates of disease are among young women who, left untreated or reinfected, may experience serious health complications and potential infertility. ACOG issued a committee opinion on September 11th on the practice of expedited partner therapy for the management of gonorrhea and chlamydia. In its opinion, the college advocates for the use of expedited partner therapy in accordance with the guidelines issued by the CDC. We support the delegates' bill explicitly permitting the practice in local departments of health and convening a work group that hopefully will look at the issue and see if it can be done in private practice. Thank you.
Thank you. Yes, sir.
Good morning, Mr. Chairman, members of the committee. Matthew Stanley, representing the American College of Nurse Midwives. We very much support the delegates' bill and the position of our friends, the OBGYNs. Thank you.
All right. Anyone else? Anyone to speak in opposition to House Bill 54? All right. Members have further questions? So, Delegate Herring, I'm a little bit, I want to make sure that we understand what it is that we're doing. So, basically, going forward, simply because a person is employed at the Department of Health, and that department is providing expedited partner therapy for those two diseases of gonorrhea and chlamydia, then going forward, there would not need to be a physical examination of the patient.
That is correct. Yes.
still kind of hung up where I was back in 2011 and 2012 when we heard this. How are we going to make sure that the diagnosis is accurate?
Well, I think this is our best shot of getting somebody to a doctor, because if the prescription is provided, sure that there's a recommendation between the doctor and the current patient that their partner needs to also go see a physician. And in my opinion, I think it's trying to get people treated, because right now, there's nothing. At least I think that we will be helping at least get people to treatment.
Alrighty, and good?
Yes, please, yes.
Thanks for that question, Lori Filano from the health department. So I think we'd agree with you that the optimal course here would ideally be to have a sexual partner be seen by a healthcare provider themselves. When those methods aren't deemed feasible, we think it's prudent. The CDC recommends this practice to ensure that the sexual partners are treated quickly. The concern of reinfection of the patient that's in front of the healthcare provider in the office is high. So this practice does contribute to expedient treatment of those sexual partners and the risk of reinfection.
And I recall a couple years ago, one of the other moving parts of conversations was giving folks, potentially giving them a sense of false security. So they come in and get one pill or one dose of antibiotics, and then there may or may not necessarily be a requirement for follow-up. We may or may not necessarily know whether that worked, because it's not 100% effective. But yet they would have a false security that now they're no longer a carrier of gonorrhea or chlamydia, and whether in fact that might have some sort of public health implications.
So the practice that the bill speaks to is EPT via prescription. The prescription would be then delivered by the patient to their sexual partners. I think you're correct that we couldn't entirely assure that that person fills that prescription, but if they do, there's 2 points. I think at the point of dispensing, the pharmacist has the opportunity to both assess a medication history and also to provide some education to that client. I think the group that would be convened could contemplate how to optimize that point of care between a pharmacist and the patient. And I do agree with Delegate that an effort to treat that sexual partner is better than no treatment of that partner.
All right, thank you very much. All right, members, anybody else have any questions? All right, I need a motion of some sort or lack thereof, one of the two. Been properly moved and seconded that House Bill 1054 as amended be reported. Further discussion? Members will cast their vote on the electronic board. And that measure advances on a 6-2 vote. You probably should be there.
I will be here.
Okay, thank you very much, Charlie. Yes, indeed, thank you. All right, next we have, who else is here? Other than Delegate Robinson. All right, and members, Delegate Pillion has sent us a letter that he wishes to strike House Bill 1175. He's going to continue to work on that substantively over the interim, so I would entertain a motion to strike House Bill 1175. Probably moved in second that House Bill 1175 be stricken for our docket. All those in favor say aye. Oh, that we do need a recorded vote. My apologies. On electronic board. All right, and that measure to strike from our docket passes on an 8-0 vote. All right, let's take up Delegate Philicorn's bill, which is. I've only been here until 1:30 in the morning reading this. I think I should know the number, but House Bill 456. Delegate Robinson, draw the committee's attention. My apologies. Told you I was up late. Members, Delegate Philicorn has sent us a letter that she wishes to strike her House Bill 456, and again, she's still need to be some work on this, and is committed to work in the interim on this issue. So, Chair will entertain a motion to strike from our docket House Bill 456. Probably moved and seconded that House Bill 456 be stricken from our docket. Members vote on the electronic voting record. All right, and the measure to strike passes on an 8-0
1378 has to do with, in Virginia, we have registered surgical assistants, and when the statute was passed, a little section that we didn't include was maintaining your registration and what would be needed to maintain your registration when you renewed. So the language is very simple. It just added that the board shall not renew registration as a registered surgical assistant for any applicant who does not present satisfactory evidence that he holds a current credential as a surgical assistant or surgical first assistant issued by the National Board of Surgical Technology and Surgical Assisting and the National Surgical Assistant Association or the National Commission for the Certification of Surgical Assistants or their successors, because those are the three bodies that do this. So that's all that it does, is it says if you want to maintain yourself as a registered surgical assistant, but you do not have to be a registered surgical assistant. If you want to maintain that, you have to have those credentials.
And Delegate Robinson, do you have amendments to your introduced 1378? No?
No, sir, I don't believe we have any amendments to it. Is it an amendment? Okay, excuse me. I guess we do have an amendment. Sorry.
Committee will be at ease for a brief moment.
Okay, so I do have some amendments. I apologize. I'll let Sarah present them.
Sure. Council.
Okay, there are 2 line amendments to the bill. First line amendment on line 22, after C, so at the beginning of that subsection, strike, the board shall not renew registration as a registered surgical assistant for any applicant who does not present satisfactory evidence that he holds a current. No, that was too far. Sorry. A surgical assistant who was registered based on, ended the word on. No, I read the wrong language. I'm sorry. It's really early in the morning.
See, it's early for all
Let
of
me
us.
start over. It's caught up to me. Strike all of line 22 and 23 through current. That was right the first time. Then insert. For renewal of a registration, a surgical assistant who was registered based on. So that will read, for renewal of a registration, a surgical assistant who is registered based on a credential as a surgical assistant or surgical first assistant, etc. Second line amendment, line 26, after the end of the line there, after successors, insert, shall attest that the credential is current at the time of renewal. So the new subsection C will read as follows. For renewal of a registration, a surgical assistant who is registered based on a credential as a surgical assistant or surgical first assistant issued by the National Board of Surgical Technology and Surgical Assisting, the National Surgical Assistant Association, or the National Commission for the Certification of Surgical Assistants or their successors, shall attest that the credential is current at the time of renewal.
All right, members understand the amendments? Without objection by general consensus, that will be amended. So 1378 again is properly before us. Members have any questions of the patron? All right, is anyone in the audience to speak in favor of House Bill 1378? Yes, sir.
Mr. Chairman, good morning. Hunter Jamerson, Association of Surgical Assistants. As Delegate Robinson said, I believe the legislative intent of the enabling legislation for the registry was to require the certification as evidence of minimum competency standards. The intent was that that certification be represented at renewal. The department identified a technical challenge in the existing law that Delegate Robinson's bill addresses. And we ask that you support the bill.
All right, sir, thank you very much. Yes, ma'am. You would come forward and just identify yourself.
Good morning. My name is Jacqueline Julian. I'm the president of the Virginia Association of Surgical Assistants. I approached Delegate Robinson about this. This is something that, as an organization, it's important for us to make sure that education is really at the forefront of what we're doing as professionals. We wanna make sure that the trust that we have with our patients when they come into us at the most vulnerable that they are, that everybody is actually doing the things they're supposed to be doing. So we most certainly do support, the continuation of credentialing in the bill. Thank you.
Thank you. Anyone else in support? Anyone in opposition to House Bill 1378, as this has been amended? All right, not the measure was with the committee. Questions, concerns? Chair needs a motion. Properly moved and seconded that House Bill 1378 as amended be reported. Members vote on electronic board. That measure advances on an 8-0 vote. All right, Delegate Robinson, and you have drawn the committee's attention to House Bill 793. And for I suspect a lot of the folks that have come today and very more than mildly curious about this bill. This is an issue that comes up from time to time, is addressing the scope of practice of individuals who are trained and competent and capable in providing services, and how that should be best done statewide. It's an issue that sometimes divides us, sometimes there's a geopolitical division, sometimes it's rural versus urban and suburban and so forth, and it draws a whole lot of attention to this. I suspect if we were to listen to each and every individual in this audience, we'd be here until late in the evening, and we simply just that's just won't work. So what I'm going to do, Delegate Robinson, is I'd like to give 10 minutes to the folks that would like to speak in favor of your legislation, 10 minutes to those that would like to speak in opposition to it. And you have had some very, very strong folks working with you in the background, and I know folks that are trying to look at it from the other side have got some strong workers as well in the background. What I'd like to do after we've heard that is bring them up, and then I would like for committee members, I would like for us to look carefully at the parts of this version that seem to differ and still be moving parts in this regard. We do not have, in my understanding, sort of a finished product that's been fully worked out, and it will be incumbent upon this committee to do that this morning. So with that, Delegate Robinson, tell us about your bill, and I understand you have a substitute as well.
Yes, Mr. Chairman, so I'd like to have the substitute distributed.
All right.
I'm gonna go ahead and
Please,
speak
yes.
because of the time. So I'm here to introduce House Bill 793, and it will give nurse practitioners full practice authority in Virginia. Last session I made a commitment to bring all the parties together and to work over the interim to make this happen. And we had representatives from the BCMP, MSB, HHA, WAMS, of course, name a few of the people who provided input to this process. Presentations included the AMA, nurse practitioner organizations, Board of Medicine, the Board of Nursing, and I met with the president and members of MSB to hear their concerns. There are 4 main changes in my substitute from the original bill that was introduced. Transition to practice would require 3,000 hours in a patient team environment with a collaborating doctor. The education standard would be codified in the legislation. The collaborating provider has to be in the MP specialty, and after transition and the MP for the MP, when they get transitioned to practice, if they decide they want to change their specialty, they will have to start the process over and go back with the collaborative agreement in that new specialty. Hours upon hours are spent crafting the language of this bill, and there were 2 areas that we did not come to consensus on, and which was the number of hours required under the collaborative agreement and who the collaborative provider could be. MSB wants 10,000 hours with a physician, and the nurse practitioners want actually less than 3,000 hours to start in the original bill, but in the substitute you'll see it's 3,000 hours with a physician or an NP that has gone through the full transition to practice. You can see, Mr. Chairman, that there's quite a disparity here. Nurse practitioners do not want to be MDs. They do not want to, but they do want to practice to their full scope of training. They have been providing competent, safe healthcare to patients for years, often in settings where the collaborating doctors are many miles away or even in another state. The state boards confirmed that over the past 7 years, there have been no cases against an MP for patient care violations. States surrounding Virginia and Washington, D.C. are getting Virginia's well-educated MPs because they already have full practice authority. West Virginia renews collaborative agreements with a physician after 3 years, and Maryland grants full practice authority after 18 months of consultation and collaboration with a physician or NP and with 3 years experience. The Veterans Administration in Virginia does not require a collaborative agreement at all. 10,000 hours will make Virginia an outlier compared to the other states, the 18 states who now have full practice authority. With our healthcare provider shortage, why do we want to discourage MPs from practicing in our state, especially when we have the opportunity to increase access to care at no cost to the Virginia taxpayer? So, Mr. Chairman, I think that kind of sums up the major differences, and there's a few things in the bill that we still probably will need some discussion on, but I open it up back to you.
All right. So members, we've heard allusion to or reference to another substitute that is there in a different format. What I'm going to ask council to do is to place that before you so that we can begin to at least embrace the differences of the two substitutes that I am aware of that are have been worked on hours and hours and hours to try to figure out how to get this right. So if you would label that just for your own perspective as whatever substitute number, and if we need to, we can refer to the 4-digit number at the top. The vehicle currently before us has 6394D as just for your documentation, and the new one that's been handed out is 6474D. All right. Do members have any questions of the patron before we listen from those that have come to give us their insights? All right. So I'd like to give 10 minutes to each side, and if I could hear from those that came to, I'm sorry, Delegate Robinson, yes.
Mr. Chairman, would it be possible before we get some testimony that we could discuss the differences between the two substitutes?
Absolutely.
Okay. Which side do you want to hear from first?
I always want to hear from your side, Delegate.
Great, thank you. I'm going to have Richard Grossman come forward.
All right.
Richard has been phenomenal to work with through this process, as so has Scott Johnson, so I just want to commend both of them for all their hard work and hours.
Good morning, sir.
Morning. Subsidies that we brought forward today, there's a number of things to change what was in the introduced bill. As mentioned, we've increased the number of hours from 1040 to 3,000. It's more in line with what other transition to practice states do, and is would not make Virginia an outlier. Other things that we heard from the committee that we included in the bill was a requirement that we spell out in code that nurse practitioners will meet a standard, meet a board certification and an accreditation that's based on national standards. In addition, we would require that the collaborating provider be in the same field specialty as the nurse practitioner, and that the nurse practitioner continue to practice only in the specialty that they have received certification in. For the most part, those are the changes into the substitute.
All right, sir. Thank you very much. All right. If we could get those that came to speak in support of House Bill 793 as it's been substituted. Delegate.
Can we hear on the other substitute, sir? Can we hear the testimony? I don't really know which substitute we're going to be working from, so I think it would be important probably for the subcommittee to hear about the other substitutes so that we can, they have knowledge on both of them before we have the discussion.
I'm seeing some heads nod. So I think, Mr. Johnson, I think you are the,
Good morning, Mr. Chairman. Scott Johnson, General Counsel for the Medical Society.
Morning,
Before I
sir.
begin, I just want to thank Delegate Robinson. We have logged a lot of time together, and on our tax return this year, I think Richard Grossman and Scott Johnson would be listed as dependents because we put a lot of hours in this, and you know, it's something that everybody's here trying to do the best they can for the patients. And you see a lot of white coats behind me. One thing about this legislation you need to keep in mind, what's behind me, these nurse practitioners and these physicians, they're the cream of the crop. What you're being asked to write today is to protect the public. And they're not in the room. The bad apples aren't in the room, and that's what you've got to navigate and go forward with that. Mr. Chairman, I've prepared a side-by-side between Delegate Robinson's substitute and the one that you have handed out. If you would like me to go through that with Richard and Delegate Robinson, that may keep us in line as opposed to just high-level comments, but I'll do what you want.
all right, that sounds like a very good plan. Richard, Mr. Grossman, you wanna come up and let's at least get before the committee so that we can try to keep this as clear as we can. Sort of the differences that still seem to be out there. And if you gentlemen would be cognizant, I absolutely need to hear from a lot of my colleagues that are in the white coats here, both nurses and doctors.
Mr. Chairman, I wasn't up to 1:30, but I was up late, and so as we go through this, I'll ask Delegate Robinson and Richard to check me and keep me honest to make sure I don't mistake something. But what I'm handing out is I endeavored to do a side-by-side. A few of the line numbers may be off, but we can catch that on the fly. Everybody's got that. Just going right through it from the top. In Delegate Robinson's substitute, they have taken out in the first two things, a patient care team and patient care team physician. Current law today says a nurse practitioner works on a patient care team and has a patient care team physician. They're removed from Delegate Robinson's substitute. In the draft that Mr. Chairman just handed out, those definitions are retained. And the reason they were retained is for the people who've not yet transitioned, so they would know how to go. The third one down in Delegate Robinson's substitute, there is a new definition of collaborating provider that, as was mentioned, would let collaboration between both a nurse practitioner and a physician. In the draft of Mr. Chairman's, it would only enable a physician to sign the attestation to permit a nurse practitioner to practice, and not a nurse practitioner.
Ms. Johnson, I hate to interrupt you here, but just for the members, there are some line numbers that are delineated on the document before you, and unfortunately they don't line up with the line numbers of the two substituted documents that you also have before you. And that unfortunately, Sarah.
I'm sorry to interrupt. The difference is just a matter of when you print the documents. There's nothing that is different about the drafts from what Mr. Johnson and Mr. Grossman have seen. It's just a matter of when the documents print, what you have before you versus what they had before them when it printed out. So I apologize for that.
Sure. All right, sorry, Ms. Johnson.
All right, the next one is the definition of the term collaboration. Delegate Robinson's substitute retains that, as does Mr. Chairman's. Collaboration, Delegate Robinson's changes that. Mr. Chairman's substitute retains that piece. The next word is consultation. That's a defined term in the code. That is retained in Delegate Robinson's draft, and it is retained in Mr. Chairman's draft because certified nurse midwives who are not being changed under this use that word. We needed to keep it. The next one down is mainly stylistic. The way the Delegate Robinson's rules of the road, if you will, are it creates exceptions when a nurse practitioner does not need a practice agreement, and then at the bottom of the paragraph it puts the general rule that you need one. In Mr. Chairman's draft, it simply reverses that and says the rule of the road is you need one unless you fall in the exceptions underneath it. So that is more grammatical. Delegate Robinson's draft removes current language from the law that permits a patient care team physician to request a nurse practitioner to have med-mal insurance. In Mr. Chairman's draft, it keeps that language because we will have nurse practitioners who have not transitioned, but for nurse practitioners who do, there is language on line 352 that says nurse practitioners that have transitioned need to have med-mal insurance equal to the cap. The next one is probably the biggest section. It's a subsection I on 588, and that is a transition to practice, and that's sort of the process of what will have to happen. There are some stylistic changes in there in Delegate Robinson's draft. In
Mr. Chairman's draft, we had some recommendations from the Department of Health Professions. So I think they're more of operational things than anything else. We are the same on the next point. If you transition to practice, you don't need a practice agreement with the patient. That's both in Delegate Robinson's draft and Mr. Chairman's. The next one is a distinction. There's nothing in Delegate Robinson's draft to talk about the type of nurse practitioner program or quality that nurse practitioner has to come from. And you've all seen on the internet, there's a lot of online learning and sign up and distance learning. And I'm not saying that's good or bad, but in Mr. Chairman's draft, we want to make sure that for nurse practitioners to transition, they have come out of a program that's accredited by the Commission on Collegiate Nursing Education. And we have checked, to the best of our knowledge, that captures all of our Virginia schools that do that. Here's the big distinction between the two sides, if you will. Delegate Robinson's draft, as she just shared, would say a nurse practitioner could transition after working 3,000 hours. Hours-wise, 1 year equals 2,000 hours. So the substitute she put before you would say a nurse practitioner could transition after a year and a half. She uses clinical hours, and that term is not defined in her substitute. Now looking at Mr. Chairman's. Mr. Chairman's substitute basically says a nurse practitioner could transition after 5 years of practice, and we use the term clinical experience. And that is a defined term, and you will hear from Mr. Grossman that he is concerned about one aspect of that definition. And I'm going to stop now and let Richard explain what his concern is, because that's okay with you.
Yes, sir, thank you.
So the problematic language would be on line 250, where you're defining the clinical experience to be with a collaborating physician that is primarily in the same practice setting. And we just need to keep in mind that the reason why we're here is we're trying to remove barriers to getting and improve access and make it easier for nurse practitioners practicing in rural and underserved areas to first get their collaborating provider, but then to also be able to transition out. I would say by including this language, you are negating what we have accomplished over the last 5 years with the bill that we passed in 2012 that established patient care teams and removed the supervision requirement. This amendment will particularly hurt those in rural and underserved areas. You'll hear from the people in rural and underserved areas. I would argue that this amendment would limit or put them out of business. It would also remove the ability to use telemedicine in the role of a collaborating physician, which is specifically allowed for in the code and what the General Assembly has been promoting over since telemedicine began. So I would really ask you right now, or as soon as we can, to remove those words from the chairman's draft.
Mr. Chairman, to respond why it's in there, telemedicine is still permitted to be used on a patient care team. Nothing in either draft takes that away. This is focusing on what has to take place between a patient care team physician and a nurse practitioner before they attest that nurse practitioner is ready to go hang their shingle. And Delegate Robinson was kind enough to come over to the Medical Society and heard from our physicians that nothing is a substitute for clinical experience. You can read how to ride a bicycle, you can watch a YouTube video on how to ride a bicycle, but until you put your feet on the pedal, you don't know how you're doing it. And our concern is if you've got a nurse practitioner that is only connected to their physician through telemedicine as opposed to being in the same shop, if you will, it's hard to address that. So that's the point there. One of the next point, I'm on the top of page 2 of the side-by-side. In both drafts, nurse practitioners will be able to transition as soon as the ink dries and this becomes law. These are not new requirements that would have to be met for our existing ones. So everybody who's a nurse practitioner in this room that is practiced the requisite time that you say would be eligible to transition in essence as soon as the regs are in place, because of the nurse practitioners out there, a lot of them have got the requisite experience, and that's true under both drafts regardless of how you go. The next point we mentioned, but it comes up in 2 places in the bill. It is Delegate Robinson's substitute that authorizes a physician or a nurse practitioner to sign the attestation. So you have a nurse practitioner that's transitioned to practice, and basically has a rookie nurse practitioner under her, she could sign it. In Mr. Chairman's draft, only a patient care team physician can sign that attestation, which is filed with the joint boards. The next one, basically the same points. Both drafts say that the attestation that somebody has completed the requisite training, both of them have them filed with the board. When you're filing it with the board, you will pay an application fee in both drafts, and then the board will issue a new license and say if a nurse practitioner's transition, there will be something on that license to say you transitioned. And that's in both drafts, and I'm not aware of any issue there. Both drafts have got language to say when a nurse practitioner transitions, he or she transitions and practices in their same field. So they've got about 10 categories that they can practice. So if I am a family practice nurse practitioner by training, by my certification, by licensure, when I transition, I'm going to stay in my lane. I'm not going to jump over and all of a sudden do cardiology unless I go back to get additional training. And basically that is a similar approach in both drafts. Both drafts have language to say after a nurse practitioner transitions, they have to comply with the standard of care and how they practice. The next two are distinctions that are in Mr. Chairman's draft, but is not in Delegate Robinson's. The first one in there is today nurse practitioners as part of a patient care team have to have a plan of how you're going to refer complex cases, how you're going to deal with emergencies, how you're going to consult other healthcare providers based on what your patient needs. We would like to see that, and it's in the Chairman's draft, that would apply to nurse practitioners who transition. The second one I mentioned earlier, but it shows up in the law, a nurse practitioner who's transitioned, the Chairman's draft would have that person be required to have medical malpractice insurance equal to the cap, so we don't have exposure. The other point now gets to prescribing. And so a nurse practitioner on a patient care team today obviously can prescribe, and that patient care team agreement between the doctor and the nurse practitioner may say you can prescribe everything or may limit it to certain things. Under this legislation, both Delegate Robinson's and Mr. Chairman, bear in mind when a nurse practitioner transition, you basically hand in a prescription pad and they make their own judgments as to what they prescribe or not. So something just to keep in mind consistent. The next one is the transition to practice on prescribing opioids. That tracks similar to the one above. The next one is a distinction. This is a put your title of your education after your name. And so in Delegate Robinson's bill, there is no naming, if you will, but in the Chairman's draft, it would say today if a doctor says, I have Dr. Scott Johnson, after my name, I've got to put something, MD, DO, DPM. There's not a simpler requirement in our law spell aid for nurse practitioners. So all this would say if a nurse practitioner has got to use NP behind their name. The next one is just clarifying there are no changes in either draft for CRNAs. They have to practice under supervision of a physician. There's no change of that in either draft. There's no change in either draft for certified nurse midwives. So this is only a change for those nurse practitioners not in those two categories, and that's true in both. The last portion of both drafts do a lot of updates on advanced practice nursing, and it's mainly terminology. That really hadn't been a debate between us, but if you wondered why so many pages in the back, that's what that's about. Take you over to the top of page 3 of the side-by-side. We have got the plan for nurse practitioners in other states, and I know Delegate Sickles has brought this up. What happens if a nurse practitioner is in Washington, D.C. that wants to come here and avail themselves to our transition laws? In Delegate Robinson's draft, it basically would say if that nurse practitioner is transitioned to D.C., they're going to be transitioned here. In Mr. Chairman's draft, it uses a process of equivalent requirements, meaning that Washington, D.C. nurse practitioner would have to sign an attestation with the physician to say, I meet the equivalent requirements of Virginia before they come. And we're not trying to bar anybody from coming, but we want to check and balance on that. This next one is a distinction between the two. Delegate Robinson's draft removes the physician-nurse practitioner ratio. The current law today says for nurse practitioners with prescriptive authority that only 6 nurse practitioners can work with one physician at any one time. Delegate Robinson's legislation would remove that ratio and allow unlimited numbers. Mr. Chairman's bill retains that ratio, and that would apply only to those nurse practitioners who not transitioned. start talking about some enactment clauses that are on the bill. In Delegate Robinson's draft, she directs the joint boards of medicine and nursing, that's the boards that regulate nurse practitioners, to promulgate regulations. In Mr. Chairman's bill, the joint boards are directed to develop regulations for nurse practitioners who transition consistent with the requirements that the Board of Medicine has on physicians. If you're going to be out there hanging a shingle, it should be the same rules of the road. The third enactment clause is a little bit different when it comes to dates. Delegate Robinson's bill would have the joint boards report back to the General Assembly on the number of nurse practitioners who've transitioned and have that report come back to you in 2023. Mr. Chairman's bill on the third enactment would have the joint boards report back to you in 2021. So it's a date distinction between that one. The fourth enactment clause is not in Delegate Robinson's bill, but it is in Mr. Chairman's bill, and this was a suggestion of Delegate Peace looking through this, and basically would have the joint boards come back to you and make recommendations of whatever years you pick or time you pick. Do those need to be modified in the future? You know, we were last here 5 years ago when we created patient care teams. This is not going to be the last day. There's got to be work going ahead, and so this is an opportunity for the experts to come back and make recommendations to you and give you those in 2021. And also, the other recommendation that would come back is if you want to look up, or your constituents want to look up a physician, they can go online to the practitioner profile, and you pull up, you know, Dr. Scott Johnson, here's where I went to school, here's where I practice, here's what insurance I take. But you can also look to see if I've got med mal cases that have been against me and paid verdicts and settlements, or if I've got disciplinary trouble. We've asked the joint boards to recommend for nurse practitioners who transition how that consumer information could be available. And finally, Mr. Chairman, in the fifth enactment clause in your bill, which is not a Delegate Robinson's, we're asking the Department of Health Professions, they track workforce. And many of you have talked with us about the need in underserved areas. And obviously we think of Delegate Campbell's area, but if you remember that we're probably a few blocks away from an underserved area in Churchill, we'd like the workforce people to come back and say, not only when nurse practitioners transition, where do they go? And also tell us, those nurse practitioners who transition, which of those 10 categories have transitioned? Are they cardiac, are they obstetrics, or they're family? Those are the distinctions I saw, and if I've left anything out or misstated anything, please correct me.
All right, before we do that, I wanted to give those concepts, those ideas for folks. This is not a finished product, but I do want to hear from the public, and we're going to get time constrained here pretty quickly. For the public's, just so you know, this is the first step of at least a 6-step process. So this bill will come before this subcommittee and will be acted upon. Should it be acted upon favorably, it'll then go to a full committee and be acted upon and discussed as well. Should it receive a favorable reading there, it will go to the floor of the House of Delegates and be debated and discussed. There are 3 days of readings of that before it's voted on. Should it in fact be favorably received through the House of Delegates, February the 13th is crossover day. All of those bills would then cross over and be taken up in the Senate. This bill would then be sent to a committee of origin in the Senate. It would probably be sent to a subcommittee there, so it would have a 4th hearing in a subcommittee in the Virginia Senate, and then subsequently in the full committee of the Virginia Senate, and then on the floor of the Virginia Senate. Should it in fact then continue on in whatever form, it would potentially still be in a conference committee to have a 7th look at it before it then would go before the governor. So for those of you who came today and you believe that you did or didn't get whatever you thought you were or weren't going to get, this is the first step in that. But I do want to hear from the public. So if we can hear from those that wish to speak in favor of this, and I just beg of your courtesy for the members. This has got a lot of moving parts. We're absolutely focused on trying to get this right. I want to go away with some product with Delegate Robinson out of today rather than no product today. So, yes, ma'am, please identify yourself. And for the folks in line, if you have some issues that are essentially have already been covered by the folks in front, if you would just state your name and tell us you're in support, because you've got 10 minutes and there's at least a dozen people behind you. Yes, ma'am.
Good morning, Chairman Garrett and members of the committee. My name is Dr. Deborah Barksdale, PhD, board-certified family nurse practitioner. I'm a past president of the National Organization of Nurse Practitioner Faculties, which is dedicated to ensuring the competency of NP programs. NP education does not look like physician education because we educate nurse practitioners. Actually, there are two organizations that oversee NP education certification. In addition to the Commission on Collegiate Nursing Education, the Accreditation Commission for Education in Nursing. Both are credentialed by the U.S. Secretary of Education, both are autonomous, and both provide rigorous standards to ensure the preparation of nurse practitioners. There are, in addition to accreditation, there are standards that all NP programs must follow that address licensure, accreditation, certification, and education, in addition to the evaluation criteria for nurse practitioner programs, which includes continuous evaluations and site visits. There's much more that I can say, but I will leave that to others. Thank you.
Thank you. Blessed be the brief.
Good morning, Chairman Garrett and members of the committee. My name is Dr. Shelley Smith, and I'm a faculty member who specializes in nurse practitioner roles and outcomes. I could review the hundreds of articles that have been published in the last 40 years demonstrating that nurse practitioner outcomes are equivalent to physician-led outcomes, but I thought that you would prefer to hear the evidence from experts outside of nursing. And those experts are AARP, the Josiah Macy Foundation, the National Governors Association, Robert Woods Johnson Foundation, the National Conference of State Legislators, and the National Academy of Medicine have all thoroughly examined the outcomes research and support removal of restrictions to full practice authority. Virginia is one of 12 states with this mandated regulation, and this arbitrary regulation is counterintuitive and not supported by outcomes evidence. There's not a single study published demonstrating a safety problem in states where nurse practitioners have full practice authority. This fact was brought forward by physician authors at Golden and colleagues in their recent publication in the Academic Medicine. Thank you.
Thank you very much. Yes, sir.
My name is Patrick Killeen. I stand here today on behalf of 1.1 million AARP members in Virginia, and we're concerned about quality and access to care. And I will be brief, although I am Irish and I've been accused of not being able to clear my throat in less than 3 minutes, but today I'll be very brief. With the growing number of older Americans as the population ages, and with the increasing physician shortage, we really believe that it is important to expand the license capacity of nurse practitioners up to the extent that their training and their education justifies. And so we support 793 or any of the substitutes that the technical changes.
Thank you very much. Yes, indeed. Yes, ma'am. Briefly.
Hi, my name is Dr. Rebecca Sutter. I'm a family nurse practitioner and associate professor of nursing. I practice both Washington, D.C. and Virginia. I am presently the co-director of a network of nurse-managed clinics in the Northern Virginia area. We have 7 sites and have trained over 550 students, serving over 10,000 patients in the pockets of underserved communities in Northern Virginia over the past 5 years. Given the clear demand for healthcare providers in underserved areas, particularly in rural communities, NPs likely will continue to be the answer to the problem in the coming years. As the National Conference of State Legislatures made clear, a number of studies have already indicated that NPs are assuming roles in the underserved rural communities in large numbers, likely due to increased demands. Evidence shows that to significantly improve placement and retention of providers in underserved areas, we need to recruit students and train them in community-based settings. Nurse practitioners in the Commonwealth of Virginia are routinely trained in community-based settings in both rural and underserved communities. Thank you for your time.
Thank you. Yes, ma'am.
Good morning. My name is Wendy Carson Smith. I'm an attorney and consultant with the Virginia Council of Nurse Practitioners, and I have worked on advanced practice nursing legislation and legislative issues for over 30 years. I'm here to speak related to nurse practitioner liability. I have provided extensive written testimony for the committee and the record, but I'm speaking to 3 issues that are within my testimony. First, malpractice rates in full practice authority states. RAND study and other data show that there is no increase but a decrease in malpractice claims in states where NPs have full practice authority. NPs and malpractice. According to the American Academy of Nurse Practitioners, nationally only 1.9% of 222,000 nurse practitioners have been named primary defendants in malpractice cases. Third, Virginia nurse practitioner malpractice and discipline. According to presentations from the Board of Medicine and the Board of Nursing, the Virginia Board of Medicine, the Virginia Board of Nursing, on the regulation of NPs, only a handful were disciplined in 2016, and most discipline that they received was reprimand, probation, and monetary privileges. In response to the substitute bill, very quickly, the National Council of State Boards of Nursing already has a process which all state boards of nursing follow when nurse practitioners move from state to state. They also have a national database called Nurses, which tracks all the disciplinary actions in states. So there is no need for that type of legislation. It is already being done. Again, I have provided extensive testimony for the committee, and I'm here to answer any questions you might have.
Thank you, ma'am. Yes, sir. We've got about 2 or 3 minutes for this side.
Thank you, Mr. Chairman, and members of the committee. My name is Rose Rittenhour, and I'm the Vice President of External and Regulatory Affairs for Bon Secours Health System. We operate 5 hospitals in the greater Richmond area, 3 in Hampton Roads, and dozens of outpatient clinics. I want to first thank Delegate Robinson for inviting us to the table during this working group. I'm here to speak on behalf of Bon Secours in support of this legislation. Delegate Robinson's substitute specifically, and I have with me Cassie Lewis from Bon Secours, who's our Director of Advanced Practice. She has a PhD in nursing and is a nurse practitioner.
All right, sir. Thank you very much. Good morning.
Hi, I'm Cassie Lewis. I'm the Director of Advanced Practice for Bon Secours Health System, Virginia, and I represent over 200 nurse practitioners throughout our organization who practice in a variety of settings, as Rhodes mentioned, across the health system to rural areas in the inner city and all throughout the Commonwealth. And without passing Delegate Robinson's bill, we are going to be terribly restricting access for patients that we serve within our organization, where right now we only have nurse practitioners practicing in some rural clinics because we cannot get physicians out there. So MSV's proposed bill would grossly restrict access to care for the patients Bon Secours Health System serves. Thank you.
And Mr. Chairman, if I may, I want to also add, in addition to access, we see Delegate Robinson's bill as an effort to cut costs and also cut regulation in our system. Thank you, Mr. Chairman.
Absolutely. All right, Brent, we got about a minute and a half.
Mr. Chairman, members of the committee, Brent Rawlings, Virginia Hospital Healthcare Association. We are supportive of this transition to practice approach, recognizing that there are many details that need to be worked out between these 2 great professions. Thank you.
Thank you, sir. Yes, ma'am.
Good morning, Mr. Chairman. I'll be brief and be gone. I'm Dr. Mary Kay Goldschmidt. I'm the Commissioner of Government Relations for the Virginia Nurses Association. I represent 108,000 RNs who fully support House Bill 793, and we respectfully ask you to consider it.
Thank you. Yes, ma'am.
Hello, I'm Dr. Paula Hill. I'm a family nurse practitioner from extreme southwestern Virginia. You all may have seen us on 60 Minutes. We actually have received national and international recognition for our quality health care. I've been a nurse practitioner for over 20 years. I work in a nurse practitioner managed clinic that has been in practice since 1980. We have, during our national, with the recognition that we have received, we also have students that have come. We have 36 collaborations with interprofessional health schools throughout the nation. With that, we train medical resident students, nurse practitioner students, nursing students, and pharmacy students. We want to see a difference in what's being done in Virginia and across the country. We are part of the answer. I want to tell you about my patients. I had one patient that came in this week. He is a retired black lung patient. He has severe black lungs, severe cardiac disease, hypertension, rheumatoid arthritis. He comes to me because there is no one else to see. We're in a severe healthcare shortage area. There are not enough physicians to take care of patients, much less nurse practitioners or nurses. My second patient I want to tell you about was not as fortunate as my coal miner that I have been seeing for several years. Her name is Glenda. She was working 2 jobs trying to make ends meet. She went to a local emergency room. She was diagnosed with a blood clot. She was given medication that she could not afford. She called around to see if a physician would see her. They would not.
We saw her, I diagnosed her with metastatic lung cancer that spread to the brain. Unfortunately, she died 3 months later. This is a national healthcare crisis. We need to do something instead of debating this. We have quality healthcare people that can take care of these patients, and I'm urging you and begging you, please make a difference in Southwest Virginia, which has 10.5-year less life expectancy than those in Northern Virginia and Fairfax. We want to have our quality care, and we want to be able to provide it to the full extent of our ability.
All right, thank you very much. So we've got, I think that's our time minutes. If those in the audience that came in support of this legislation, if you could just raise your hands, don't stand, because it'll take. All right? All right, thank you all very much, and thank you for your advocacy. Please hang with me, folks, because if we want to get this through, we need to get through. I would like to now give 10 minutes to the side of those that came in opposition of this legislation.
Thank you, Mr. Chairman. We've got 3 witnesses who would like to testify in support of the substitute and talk with you a little bit. The first one is the president of the Medical Society, Dr. Elwood from Charlottesville.
All right, sir. Good morning, sir.
Good morning. Good morning, Mr. Chairman and members of the committee. My name is Kurt Elwood. I'm a family physician from Charlottesville, and I'm currently the president of the Medical Society of Virginia. Having been in practice for over 30 years, I've experienced with many excellent nurse practitioner colleagues in collaborative care arrangements, which have greatly benefited patients. I have the utmost respect for them. Yet I'm concerned that 793 will allow nurse practitioners to practice medicine independently after very little time, 6 months, and merely 3,500 hours, and that this will remove physicians from the care team. I'd like to share with you the reasons why I and our 10,000 members oppose it. Now, some would say that this is simply about turf, and I'm here to convey to you that it is not about turf or ego or money. If it's about turf, it's that we feel the best possible team on the playing field for the benefits of our patients, and get the ball down the field to the patient's goal with collaboration and teamwork. The patients clearly benefit from a physician leading the healthcare team, and currently physicians and nurse practitioners can have a collaborative relationship that provides a lot of flexibility for the nurse practitioner, yet also includes physician-led team-based approach. You may have seen materials from the Institute of Medicine regarding nurse practitioners and their scope of practice. Indeed, NPs have already the full scope of practice as outlined by the National Council of State Boards of Nursing in that Iowa report. Now, the practice of good medicine requires rigorous training. Physicians are required to complete 4 years of medical school, 3 to 8 years of residency, and 12,000 to over 15,000 hours of rigorously supervised clinical training. On the other hand, there is a broad variation in nurse practitioner programs, many of which are online, require less than 1,500 hours of clinical training, which is a small fraction of that required for doctors. Now, working to the top of one's license is different when you have 3,000 versus 12,000 hours. Supporters of this bill have cited studies that purport to demonstrate equality of outcomes, but these studies primarily are based on data which are very clinically structured and narrow in their setting, and are still under physician leadership. Moreover, with the capabilities of telemedicine and communication today, it is easier than ever to collaborate and ensure that proper clinical supervision is maintained. And the nurse practitioners in areas where they're providing needed access have all the support they need, and the patients as well. So now is not the time to abandon the team approach. Let's protect our healthcare team and deliver the highest quality care possible. Thank you.
All right, thank you, Dr. Elwood. Yes, sir. Come on forward.
Good morning.
Good morning, sir.
My name is Michael Pierce. I grew up in Woodstock, Virginia. I went to UVA for undergrad. I'm now a second-year medical student at Eastern Virginia Medical School. I'm here in opposition of House Bill 793. I want to make it clear that I am in support of the chairman's substitution. House Bill 793 would remove a physician from the patient care team. I chose to go to medical school because it's the most rigorous academic experience and one that will allow me to safely care for my patients. Medical school is a 4-year, full-time, in-person education. Over my 4 years, I'll learn biomedical sciences, clinical sciences, pharmacology, and most importantly, how to apply all of that to safely care for my patients. Even after I graduate medical school, I will still be under the supervision of physicians. I'll complete a 3 to 8 year residency program, which is a training program in my specialty. I'll also have to pass 4 national licensing exams that test my knowledge in science, medicine, and how to apply that to care for my patients. Only after medical school, residency, and passing those 4 exams will I be able to treat patients and prescribe independently. I'm concerned about how House Bill 793 will impact patient care in Virginia. Primary care is one of the most complicated fields in medicine. It's also the lowest paid field in medicine. Why would someone who dedicated 10 years and hundreds of thousands of dollars choose to go into a field that can be eliminated by someone who got a degree faster and cheaper?
What?
Every pilot is trained to fly a plane. Every pilot is trained to fly a plane. But you really want someone who's been trained to fly a 2-person Cessna landing your 747? It's about having the right person and the right role. The patient care team needs to be complete. It needs to include physicians and nurse practitioners to ensure that every patient gets the care that they deserve. Thank you.
All right, Chief. And if you please identify yourself. Thank you.
Good morning, Mr. Chairman, members of the subcommittee. I'm Dr. Karen Ransom, a pediatrician from Deltaville, Virginia, and a former president of the Board of Medicine. Throughout my 28-year career, I've worked alongside many nurse practitioners. I'm here today to voice my opposition to House Bill 793.
And Karen, I don't want to interrupt you, but 793 as introduced, 793 as the current substitute that's before us, or 793 as what we've talked about as being in contrast?
Yes.
You're in opposite. Okay, gentlemen, thank you. I didn't want to interrupt.
That's all right. As a physician who practices in a medically underserved area, I admire the goal of increasing access to medical care for Virginians. However, this bill will not increase access to care. There's no current restrictions on where nurse practitioners can live or work in Virginia. Yet, according to a 2016 Virginia Department of Health Professions survey, 74% of nurse practitioners chose to practice in the 3 most populated areas of the state. Despite the ability to do so, nurse practitioners have not moved into underserved areas in large numbers. And nothing in this bill will encourage them to do that. In states that currently allow independent practice, data shows that this fails to increase access to medical care, especially in underserved areas. Virginia's underserved areas have high rates of unemployment and low rates of insurance coverage. This combines to make it difficult for many to pay for medical care, which in turn makes it difficult for all health providers to sustain a viable practice. Instead of removing a patient's access to a physician, I ask that the committee consider proven solutions for increasing access to care, such as low repayment options, which would enable a doctor to pay back their high medical education costs while providing care in those underserved areas. I urge you to vote no on this bill. It will not improve access to care in medically underserved areas and will only reduce patient access to highly trained physicians. Thank you.
All right.
I will wrap up, and I've certainly.
All right. Before you do that, Ms. Johnson, would all those that came in opposition to 793 also raise their hands that are here in the audience? All right. Thank you. And I actually see a number of former presidents of the Medical Society of Virginia here as well. So, all right, sir.
Mr. Chairman, I'm glad to answer any questions regarding the difference between your substitute and Delegate Robinson's substitute. They're meaningful. But, obviously the amount of clinical experience required before transition is key. And some may say, why are you looking at 5 years? We want to make sure when you go back to your local law enforcement and your sheriffs and your deputies say, we have got nurse practitioners that are now transitioned and able to hang out a shingle. I have a lot more comfort thinking you're going to answer the question that somebody who's worked 5 years, is 30 years old, that's got to cover a prescription pad is out there, as opposed to somebody that's worked a year and a half and they're 25 years old, given our opioid crisis and the other challenges we face. Thank you.
All right. So, Delegate Robinson, well, before you do that, members, do you all have any questions given where we have? I want to make sure everybody has a comfort level of where they are. Delegate Sickles.
Thank you, Mr. Chairman. I have a lot of questions, but we don't have enough time for them. But I'm just so curious about how people can survive in these other states that allow nurse practitioners to practice with more freedom. I want to get to the right regulatory scheme. I want to make sure any nurse practitioner knows when to consult a doctor. So if that is the most important thing, because the testimony that we are removing access to a physician and reducing access a lot of the testimony on behalf of the nurse practitioners did not really get into the details of these two substitutes. So I'd really like to hear someone talk about the other states and why you think that that 18 months is a good enough time period for you to be able to practice on your own that shorter period.
And if you would very briefly sort of give an answer as best you can.
Yes, sir, that's a great question. So national outcomes data shows us that there's no evidence to support that any transition period is necessary. But when you look at transitional states, the average length of time is 18 months. The maximum time is 3 years. 10,000 hours is 5 times greater than what is already present. There's no national precedent for that. I think, does that answer your question?
Yes, Mr. Chairman, it helps.
Thank you very much. All right, and again, members, just to make sure we understand this. So after a individual receives his or her registered nurse degree, which is typically a 4-year program, then they do a typically 2-year program and so forth to get their master's. And then what is proposed before us is after they then begin their practice as a nurse practitioner, a year and a half later, they would, if an attestor, their physician or nurse practitioner, as this is written, affiliate or the person that they're working with them, attest that in fact they're competent and capable, then they would be allowed to practice independently. The other issue before us is whether in fact they ought to have 5 years of clinical experience, and that's going to be for each member to try to decide which you believe is now going to create enough of a level of competency that we can assure the public that, because our duty is to make sure that the public gets their access, but they do so safely and competently. All right, other members have other questions? No? All right, Delegate Robinson, why don't you wrap up for us? And then we'll put this in whatever posture the committee wishes.
I think Scott did an excellent job in comparing my substitute to your substitute. I'll just call it Mr. Chairman's substitute. There were a few things that I think were a little misleading. Some of the things that he compared in that were the languages in the chairman's is already in code, like the identification of why you have to identify yourself as a nurse practitioner. You can't identify yourself as just doctor, the same thing as an optometrist. I'm not allowed to hang out my shingle that says Dr. Roxanne Robinson without identifying myself as an optometrist. And that's already in code, so we didn't necessarily repeat that in this piece of legislation just because it's already in code. There's no place in existing code that requires anyone to have malpractice insurance. I mean, it's not written in the code for a profession, and that's why it's not included in my version, because it's not in the code. The enactment clauses at the end of it, Scott had presented this back to DHP, and some of these suggestions that are in there were things that DHP suggested, and I don't think there was any really any heartburn about any of that being in the bill. So some of the things that are spelled out in that version aren't in mine just because it's already existing in code or already here in practice. As far as NPs not consulting with physicians, as I think they know their limitations. They don't want to be doctors, but they go to school for a long time. And to be a doctor, have your doctorate as a nurse practitioner, you're going to school 2 to 5 years. In addition to your 4 years. So it's kind of misleading when we hear that they don't go to school and they're not trained the same. As far as telemedicine goes and being able to use that from remote areas, we do that now. It's in the code now. It's being done now. The testimony from Southwest Virginia, and she doesn't have a physician. She has the capability of that consultation and that collaboration. So all those things are practicing things that nurse practitioners currently do. And because we grant them full practice authority, does not mean that they're going to change their way of practice and all of a sudden be these independent individuals. They have a standard, a code of ethics that they also practice by, just like physicians do. And so I think we need to respect that and grant them full practice authority in the Commonwealth.
All right, Delegate, thank you very much. we do need to get through this. You've done a great job advocating. Delegate Robinson and I sincerely appreciate that. Members, do y'all have any other questions about what's currently before us and what our options are? Delegate Sickles.
Mr. Chairman, I think that there are many provisions that in your substitute that might be considered that are not necessarily harmful to the interests of the nurse practitioner issue here. So I think there needs to be more work done to bring these two things together. On the larger issue, maybe there's a further compromise between the hours of practice you need to do, but for the purpose of moving this along, I would move her substitute at the appropriate time. The proponent's substitute, Delegate Robinson's at the appropriate time.
All right, it is the appropriate time because, yes, sir. All right.
Move to report the bill with the caveat that there's work to be done on it.
Well, let's get it probably before. So what Delegate Sickles has offered as a motion is to accept the second substitute that we've been discussing.
This is the chairman's substitute?
Yes, ma'am.
No, Mr. Chairman, that's not what I was moving. I was going to move the Delegate Robinson's substitute as the document that we would work from going forward with the caveat that there's many provisions that sounded reasonable in your draft that we can incorporate into this document, but we do have to come to terms with the big two issues here. But I was going to move hers as just the platform to work from. That's my motion.
I misspoke. Thank you very much, Delegate. All right, that fails for lack of a second. Delegate Campbell.
Delegate Robinson, I'm a lawyer, so I'm the most light guy in there. But I'm curious as to why your bill doesn't have a requirement for medical malpractice code.
It just doesn't, because there's no place in the code that any profession has that as a requirement in the code. So that's why it's not in there.
You would agree with me that this is a change in the way.
But I think they currently have medical malpractice insurance. I mean, they have it. I mean, that's you have to have that basically. I mean, I understand that. I mean, if somebody wants to stand up and talk about what they have to have, they would be more knowledgeable in that. But they either have it through their employer, if they're at the hospital or whatever, or Health Wagon nurse. I mean, she maybe will talk about that more. But
the need for medical malpractice would be fine. Having the board decide, what the requirements would be, but to set the precedent that we put it in the code, you don't exactly do that for any other health profession. It wouldn't negate our need to have it, and if we wanted to be protected by the cap, we should have it.
All right. Further questions of the.
Do you want her to address that same question?
Well, Delegate Campbell, did you get your question answered?
Well, I did, but with regard to the health wagon, yes, I would like to hear that.
Okay. I'm Rachel Helton, the Director of Development of Health Wagon. We serve the far southwest 6 counties, Lee, Wise, Scott, Dickinson, Buchanan, Russell. I just wanted to mention we currently have 5 nurse practitioners working under Dr. Joseph Smitty, who's a medical doctor. And as a nonprofit, how we are structured, we require each nurse practitioner to be licensed and to be insured.
And that's just kind of basic. I think most organizations that you're going to be employing nurse practitioners or physicians, they're going to require malpractice insurance because this is the day that we live in. So I don't even think that would be an issue if anyone wants to put it in because, you can't be brain dead and not practice without malpractice insurance.
I agree. I'm just saying that the issue was raised.
Delegate Campbell, I'm sorry. So we don't just do it back and forth up there.
Mr. Chairman, just one
Yes, sir.
comment. I guess I understand what you're saying, but it was raised as an issue in the chairman's substitute. There's a difference between the two. So I appreciate that.
members have any other questions? All right. Delegate Robinson, thank you very much for advocating for strongly for your folks.
Thank
And I appreciate that, absolutely. All right, it is 8:32. We only have one more bill on our docket, which is.
Mr. Chairman, can you tell me what just happened?
So,
Mr. Chairman.
Delegate Peace.
Mr. Chairman, picking up on what Delegate Sickles was saying, maybe to clear things up for Delegate Robinson, I've got a motion to make.
Yes, sir.
Mr. Chairman, I move that we adopt the chairman's substitute with a line amendment on line 250, putting a period after physician and deleting primarily in the same practice setting. I'd like to speak to the motion. I move that we adopt the substitute, and I've got another amendment after we do that.
All right, it's been probably moved and seconded that the substitute that we've been referring and making reference to be adopted, and that's been probably moved and seconded. Without objection and by general consensus, that'll be so. So now,
So, Mr. Chairman,
House Bill 793 is back before us.
I'd further move that we delete primarily in the same practice setting language on line 250. And my concern is, Mr. Chairman, that if there's a second to that, I can speak to.
All right, it's been probably moved and seconded that that amendment be introduced as well.
Mr. Chairman,
without objection, and so.
You know, we've heard a lot about this issue over the last several weeks. I think the parties are actually a lot closer than what we have heard this morning. I think there are a few hang-ups that I think could be worked out in the process. As you've recognized, Mr. Chairman, that there are several evolutions and stages that we still have to go. And we believe in keeping the physician as part of the patient care team. We believe that the hours should be substantial. We don't know exactly what that should be. But access, costs, and quality are things that we need to reconcile and balance and preserve because it's very important. I was particularly moved by the health wagon representative representing a rural area myself. I was very concerned about how limiting primarily in the same practice setting would affect rural communities. And so that's why I make that technical motion to amend your substitute, Mr. Chairman, and keep the conversation going.
A little bit more than technical, but I'll certainly accept that for what it's represented. And I appreciate your statesmanship, Delegate Peace, and I say that sincerely. All right, do the members know what's before us?
Mr. Chairman.
Delegate Sickles?
No.
Could you So,
thank you.
Committee, what's properly before us now is the document that last four digits are 6474D, that, as amended by Delegate Peace on line 250, after the word patient care team physician, to strike the rest of that line, primarily in the same practice setting. Delegate Hodges, you look quizzical. We have adopted them. We did it by general consensus and without opposition. If you'd like to pose, I can have a. No, we're good. All right. And thank you, Council. Council reminds me that we may well be able to need to make that technical consideration several other places in this document. So, all right. Do members have a question of now what is before us?
Mr. Chairman, we're moving the amendment substitute as amended.
Yes, sir.
Thank you.
Well, that is what is before us.
Mr. Chairman, just for clarification, this will continue to be my bill, not the chairman's bill as it moves through the process, just for clarification.
Trust me, Delegate, this says House Bill 793, and the patron is Delegate Robinson.
Thank you, Mr. Chairman.
So this young
We've worked
surgeon,
really, really hard on this.
I respect that. This young surgeon and my statesman friend to my right and my statesman friend to the left, we're just trying to get it right, but it ain't my bill.
I appreciate that, sir.
Mr. Chairman, I move that we recommend reporting House Bill 793 as amended.
It's been probably moved and seconded that House Bill 793 as substituted by that designation 6474 as amended on line 250 be reported. Is there any further discussion to that motion? All the members understand what we're voting on? The members will vote on the electronic board. 9-0 vote. So again, for
Thank
the public,
you very, very much.
for the public's perspective, from the public's perspective, this is first step in a multi-step process. Hang with me, everybody, please. I encourage you to communicate with your delegates. You don't necessarily with the senators letter. I don't understand. I don't believe that there's a conjugate or a comparable in this sense. Hang with me. If you all, I encourage you to communicate with your delegates and to represent what you see as the moving parts of this and what needs to go forward. I understand from Chairman Orrock, there will not be a full hearing of this when this comes before the full committee. He is very grateful that many of the folks that wish to speak to this, not all the folks, but many are here today, and I truly do believe that had a full and fair hearing. Members, the only other bill that is before us is my bill. I chose to take it by to grant enough courtesy for the folks that have traveled today. I will ask the consideration of the chairman to bring this up, my bill, House Bill 1303, before the full committee. So I would ask that it be taken by for the day. All right, without exception. All right, anything else to come before us? Our committee will rise. Thank you very much.